everyone, welcome to Try Night. This is Pack 365. Myself Srija. In this session today, you're going to learn about the CPT coding guidelines which are applicable within the surgery section of the respiratory system. So how respiratory CPT codes are organized? So they are arranged by the anatomical side moving top to bottom. So what are the orders in CPT code book? Nose and nasal cavity, sinuses, pharynx and larynx, trachea, bronchi, lungs and pleura. So mouth and throat procedures which are not always respiratory. So procedures on the mouth and throat may be listed under the digestive system but not the respiratory. Why? Because these are the anatomically shaped area. So CPT assigns codes based upon the primary system involved. For example, tonsillectomy, it is a digestive system code. Esophagoscopy, it's a digestive system code. And bronchoscopy, it's a respiratory system code. So if the procedure involves a swallowing or a food passage, you have to think it as a digestive. So what is the external versus internal approach? So external approach, it includes the integument system codes, whereas internal approach, it includes the respiratory system codes. So for example, external incision on the neck. So what are the correct codes involved? Integumentary. Whereas endoscope passed into an airway, it's a respiratory code system. So next is bilateral procedures modifier 50. So what is modifier 50? It indicates a procedure performed on both sides during the same section. So when to use modifier 50? Within the same procedure, if a same physician is used and same operative session. So both sides of paid organs are getting treated or getting surgery within the same session. So what are the examples of paid organs? Lungs, bronchi, nasal cavities and ears. For example, bronchoscopy with biopsy done in both lungs. So you have to assign the code for bronchoscopy with biopsy, plus you have to assign the modifier 50 as an add-on code. Modifier 50 versus LT and RT, which is a very common one. So modifier 50 used when both sides are treated. So reported on one line only. So do not use left side LT with modifier 50. So modifiers LT and RT, these are used only when only one side is treated, which are used to identify which side. So never do this. Never assign the CPT code. Never give LT plus RT with the combination of the modifier 50. So when to use LT or RT instead of modifier 50? So you have to use LT or RT when only one side is treated. So when payer requires site-specific reporting. For example, lung biopsy is done on right lung only. So you have to assign the code, CPT code plus assign the RT modifier instead of the 50 modifier. So same operative area versus a separate operative area. So modifier 50 applies when procedures are done on paid organs in separate areas. For example, hands, feet and lungs, or in the same operative area, nose, eyes and breast. So same code, same day, two sides. You have to think of the modifier 50. So billing a procedure on two separate lines using LT and RT is not the same as reporting a bilateral procedure with modifier 50. So what is the correct rule here? Modifier 50 is a preferred method for reporting the bilateral procedures unless the payer specifically requires LT or RT. So modifier 50 means same procedure was done on both sides. So it is reported on only one line. For example, LT or RT, it is used when only one side is treated or when payer requires site-specific reporting. So never combine modifier 50 plus LT or RT within the same line. And next, the first concept within the respiratory system is endoscopy. It's a basic concept. So what is an endoscopy? It's a procedure that allows the doctor to look inside the body using a scope. So nasal endoscopy. So this is used to examine the nasal cavity and sinuses. So this is performed using a thin flexible tube with camera and light. So who performs this endoscopy? ENT specialist, who is also called as otolaryngologist. So this is often done in the office but not the operating room. And this is a very important bundling rule. So when bronchoscopy is performed, nasal endoscopy and laryngoscopy are also included. So do not quote this nasal endoscopy or this laryngoscopy separately when bronchoscopy is done. Why? Because the nasal cavity, pharynx and larynx, these are the access routes. So CPD considers them as routine and bundled. For example, procedure performed, patient is diagnosed and the procedure performed is nasal endoscopy, laryngoscopy and bronchoscopy. So what is the correct coding? You have to report only the bronchoscopy code. So what is the incorrect coding? Bronchoscopy. So do not assign the codes for nasal endoscopy and laryngoscopy with the bronchoscopy. So everything is considered under the bronchoscopy. And multiple endoscopies in the same session. So when multiple endoscopy procedures are performed in the same session, so you can report more than one endoscopy but follow the relative value units and modifier rules. So what are this RVU rule plus modify 51? So what are these RVUs? These are the relative value units. So these represent the work, time and complexity of a procedure. So report the procedure with highest RVU as a primary code and report the additional procedures with modifier 51. So what are the examples? So procedures performed are bronchoscopy with biopsy which has a higher RVU value and bronchoscopy, bronchoalveolar lavage which has a lower RVU value. So what is the correct coding? You have to assign always the highest RVU first, followed by lower RVU value secondary. So example, here is an example, multiple bronchoscopies in one session. So what is a given example? Physician perform bronchoscopy with biopsy, bronchoscopy with removal of the foreign body. So what is the correct CPT coding? 31628 for bronchoscopy with biopsy, 31635 with modify 51 for bronchoscopy with removal of the foreign body. So this is assigned as a secondary procedure. So why modify 51 is used? Because both are bronchoscopies and both are performed within the same session. So CPD rules say report the highest RVU code first as it is 31628 and add modify 51 to the lower RVU code as it is 3163551. So diagnostic nasal endoscopy codes. So what these codes represent? 31231 to 31235. So these codes describe the diagnostic nasal or sinus endoscopy where the provider inspects the nasal cavity, middle and superior meatus, turbinates and sphenoethmoid recess. So these areas, they are automatically included in the diagnostic exam. So do not code each area separately. So one diagnostic endoscopy code covers all of these areas. Diagnostic evaluation rule. So what does it mean? So whenever a diagnostic nasal endoscopy is performed, so all these areas are routinely inspected. So no additional CPT codes are reported for each structure. So why CPT does this? Because to prevent the unbundling, to ensure fair and standardized billing for the provider. Next guideline is unilateral versus bilateral procedure. 31233 to 31297 CPT codes. So these codes, they are unilateral by default. So only one side is assumed unless the code says bilateral. So if it is done on both sides, you have to use modify 50 if the pair allows, or you have to report LT and RT on separate lines if the pair is dependent. So if CPT does not say bilateral, you have to assume it as an unilateral procedure. Next guideline is sinus ostial dilation codes. The code range is 31295 to 297. So what does this code describe? It describes the dilation, nothing but the widening of the sinus openings, which is achieved by displacing the tissue. This can be done by any method, balloon, instruments, etc. So in these cases, the fluoroscopy is included. So do not build the fluoroscopy separately. And next is modifier 52. Nothing but reduced services. So what does modifier 52 means? The provider intentionally reduced the service and decision made by choice but not because of a problem. So when to use modifier 52? When there is a diagnostic or surgical service, less work performed than the CPT description and the procedure is still completed but not fully completed. So example like a planned full nasal endoscopy. So only partial exam performed due to patient discomfort So you have to assign the CPT code plus modifier 52. Modifier 53, discontinued services. So what does modifier 53 means? Procedure was started but stopped. It is discontinued due to patient instability or bleeding or any other safety concerns. For example, bronchoscopy started, so oxygen levels dropped. So the procedure is stopped by the provider. So you have to assign CPT code plus modifier 53 in these cases. So this is how you have to assign modifier 52 and 53 according to the circumstances. Accessory sinuses. So what this mean? Accessory sinuses and the surgical sinus endoscopy. So a surgical sinus endoscopy automatically includes the diagnostic endoscopy and the sinusotomy when appropriate. So when a surgeon performs endoscopic sinus surgery, they must first look inside. That is a diagnostic procedure and may then open the sinus. Nothing but sinusotomy procedure. So CPD considers a diagnostic part bundled into a surgical procedure. So do not code the diagnostic sinus endoscopy separately. You have to code only the surgical sinus endoscopy. Next session is larynx. So what does this codes cover? The CPD code range is 31,505 to 579. These codes, they are used to report the laryngoscopy procedures which examine or treat the larynx, nothing but a voice box. So the anatomy of the larynx contains vocal cords, epiglottis and entrance to the trachea. So larynx is, it generates the voice, it gives airway protection and it helps in breathing. Diagnostic versus therapeutic rule, which is a high yield one. So if both diagnostic and therapeutic laryngoscopy are performed, so code only the therapeutic procedure. So why? Because diagnostic work is considered included. It prevents the unbundling. So the example is diagnostic laryngoscopy and also removal of the vocal cord lesion. So in these cases, you have to code therapeutic laryngoscopy only. Do not code the diagnostic exam separately. And the next guideline regarding indirect laryngoscopy. CPT code ranges 31,505 to 513. So what is an indirect laryngoscopy? So in this procedure, the provider uses a mirror, so held at back of the throat, and it's an older and simple technique. So what can be done with this indirect procedure? Diagnostic examination, biopsy, removal of the foreign body, removal of the lesion, and injection of the vocal cords. So setting. So this is often performed in the office, and this procedure, it usually requires no anesthesia, no general anesthesia. Next procedure is direct laryngoscopy. So what is a direct laryngoscopy? It uses a rigid or flexible laryngoscope. It is inserted through the mouth. It allows direct visualization of the larynx, vocal cords and adjacent structures. So this is usually done in the operating room under general anesthesia. And here are common direct laryngoscopy codes. 31,535 laryngoscopy direct operative with biopsy. So this means there is direct visualization of the larynx. Tissue sample is taken here and both diagnostic plus surgical procedures is done within one procedure. So always biopsy is included. So do not code biopsy separately. And putting it all together. So surgical sinus endoscopy includes diagnostic exam, diagnostic therapeutic laryngoscopy, they code therapeutic only. So mirror means using of a mirror indicates indirect laryngoscopy. So using of a scope, it indicates direct laryngoscopy. And 31536 CPT code with operating microscope or telescope. So direct laryngoscope is used by operating microscope or telescope. So it involves magnification using the microscope or telescope. So this is included within the code description. Do not bill separately for the magnification again. So if the code already says with operating microscope, never add a separate microscope code here. And the next is CPT code 31575. Laryngoscopy, flexible, fiber optic, diagnostic. So this uses a flexible fiber optic scope which is performed through nose or mouth. So the purpose of this is diagnosis only. This is commonly done in the office. So what are the indications? Hoarseness, voice changes, suspected vocal cord paralysis, and chronic throat symptoms. And what are the clinical examples? Scenario from the slide is patient with persistent maxillary sinusitis and the symptoms of hoarseness of the voice. So ENT performs detailed history, detailed examination, medication adjustment, and flexible fiber optic laryngoscopy. So the main procedure here is finding the paralyzed vocal cord. So why both E&M and laryngoscopy are reported? So reported codes here is 9921-425 for office visit, which is an E&M code, evaluation management code, 31575 for diagnostic flexible laryngoscopy. And here why modifier 25 is needed? Because modifier 25 tells the payer the E&M service was separate and significant but not just a part of the procedure. And next code, CPT code 31520, diagnostic laryngoscopy of a newborn. So what this code is? It's a diagnostic laryngoscopy which is used in newborns or infants. Modifier 63, the procedure performed on infants less than 4 kg. So you have to use modifier 63 when infants weigh less than 4 kg and procedure is more difficult and risky in these cases. So because CPT already accounts for the complexity of the newborn procedures. And Appendix F. So why it matters? What Appendix F is? It's a CPT appendix that lists codes exempt from the modifier 63. So many codes in the 2005, 2005 to 69,990 series are not allowed to use modifier 63. So you have to always check Appendix F before adding modifier 63 to the CPT code. So next section is trachea and bronchi. So this slide explains endoscopic procedures of the airway, specifically trachea, the windpipe and main bronchi, left and right. So these procedures are reported using bronchoscopy CPT codes. So what are the CPT code ranges for trachea and bronchi? 31615 to 31661. So what does this mean? All endoscopic procedures involving trachea, right bronchus and left bronchus are reported using these codes. So always choose the code based upon the deepest anatomic site examined or treated. So you have to code the appropriate endoscopy of each anatomic site examined. If the physician examines trachea only, you have to use tracheal bronchoscopy code. If there is a trachea plus one bronchus, you have to use bronchial code. And trachea plus both bronchi, you have to assign bilateral bronchial code if allowed. So you do not code trachea and bronchi separately. Bronchial codes already include the tracheal examination. And diagnostic versus surgical bronchoscopy code rule. So what it is? Surgical bronchoscopy always includes the diagnostic bronchoscopy when performed. So what this means? Diagnostic bronchoscopy is a bundle. If both are done, do not code diagnostic separately. You have to code only the surgical or therapeutic procedure. Diagnostic bronchoscopy is never reported separately when a surgical bronchoscopy is done. And diagnostic bronchoscopy, what is the overview? What is the purpose? For visual inspection to identify the tumors, foreign bodies, bleeding and inflammation. So what are the common diagnostic codes? 31615, that is assigned for tracheobronchoscopy diagnostic, which is often done for chronic cough, hemoptysis and abnormal imaging. Whereas surgical bronchoscopy examples are biopsy, removal of the foreign body, tumor destruction and stent placement. And here in this picture you can see the bronchoscopy, the endoscope is inserted into the bronchus. Name bronchoscopy procedure is done here. Bronchoscope passes through a trachea before reaching the bronchi, which is why trachea is bundled in this procedure. So next is laryngoscopy procedure. So what is laryngoscopy? It's an examination that allows the doctor to see the larynx, nothing but a voice box, and throat. So why it's important? The larynx sits at the top of the trachea, which is a windpipe. So it contains the vocal cords which are essential for speaking, breathing and protecting the airway during the swallowing. So the clinical reasons for laryngoscopy are hoarseness, voice change, throat pain, chronic cough and suspected tumors or vocal cord paralysis. So there are types of laryngoscopy. Indirect laryngoscopy, direct fiber optic laryngoscopy and direct laryngoscopy. So what is an indirect laryngoscopy? It's the simplest and oldest method which uses a small mirror and a light source. So how it's done? So patient sits upright in a chair. So doctor places a small mirror at the back of the throat. So light is shined into the mouth. The larynx is seen indirectly in the mirror. So similar to tools used by the dentist. So where it's performed, it is usually performed in the doctor's office. So there is no operating room needed. And the patient experience is they may spray local anesthetic to numb the throat. They can trigger a gag reflex. So what can be done with indirect laryngoscopy? Diagnostic viewing. So minor procedures such as biopsy, foreign body removal, lesion removal and vocal cord injection. So the CPT code range for indirect laryngoscopy is 31505 to 31513. And next is direct fiber optic laryngoscopy. So what it is, it uses a thin flexible fiber optic scope which provides a direct clear view of the larynx and also called as flexible laryngoscopy and fiber optic laryngoscopy. Now how it's done? So scope is usually passed through the nose, patient is awake and local anesthetic is applied to the nose or throat. So why it's commonly used today? Because for better visualization and there will be a less gag reflex. So they can also see the vocal cord movement, subtle lesions and paralysis. So it's always done in the office and outpatient setting. So what is an example? 31575 laryngoscopy flexible fiber optic diagnostic procedure. And next is the direct laryngoscopy. So direct laryngoscopy, it's a more involved procedure where the doctor directly visualizes the larynx using a rigid laryngoscope. So what instrument is used here? A laryngoscopic blade. For example, Macintosh or Miller blade, which is inserted through the mouth as shown in this image. So this is used to push the tongue downward and lift the epiglottis upward. So now what is the role of epiglottis in this direct laryngoscopy? The epiglottis is a cartilage flap that opens during breathing and closes during swallowing to prevent the food entering the airway. So lifting the epiglottis exposes the vocal cords and glottis, which is the airway opening. So now what are the indications of a direct laryngoscopy? Removal of the foreign bodies, biopsy of the laryngeal lesions, evaluation of the tumors and endotracheal intubation, which is very important in anesthesia and emergency medicine. So what kind of anesthesia is involved in this procedure? It is usually done under the general anesthesia, especially in the surgery and also sometimes in the deep sedation. And next procedure is bronchoscopy. So bronchoscopy is a procedure that allows doctors to directly see the inside of the trachea and bronchi. So it is most commonly performed by a pulmonologist who is a lung specialist. And it's an instrument used, a bronchoscope. It's a thin flexible tube with light source, camera and a working channel for instruments. So some cases use a rigid bronchoscope mainly for the emergencies or a foreign body removal. Now what is the route of insertion? So it is passed through the mouth or nose, down to the throat and into the trachea, then into the bronchi and lungs. So diagram on the right shows the bronchoscope entering the airway. So trachea dividing into the bronchi and the area of lung pathology, for example, cancer. So anesthesia and duration of the bronchoscopy. It takes longer than the simple laryngoscopy. It is usually done under moderate sedation or general anesthesia. So during bronchoscopy, the patient is not fully awake, which reduces discomfort and it prevents the coughing and gagging. So why is bronchoscopy done? So what are the diagnostic uses? To take the biopsy samples of the lung or airway tissue, to identify the lung cancer, infections like tuberculosis, pneumonia, inflammation, bleeding sores, and also to evaluate the abnormal imaging by using X-ray or CT findings. And what are the therapeutic uses? So this bronchoscopy removes mucus plugs, foreign bodies, small tumors or growths, control airway bleeding and place the stents in narrowed airways. So what is an airway management now? They can be used to insert an endotracheal tube into the trachea, assist the breathing during the surgery, emergency situations and also difficult airway cases. And next procedure is thoracocentesis. So what is thoracocentesis? It's also called as thoracocentesis or thoracentesis. So it's a pleural tap or a needle thoracostomy. It's an invasive medical procedure in which a needle or a catheter is inserted into the pleural space to remove the air or fluid. Now what is this pleural space? It's a potential space between the lung and the chest wall. So why is thoracocentesis done? Its main purpose is to remove the pleural effusion, the excess fluid in the pleural space, which compresses the lung, causes the shortness of the breath, and also prevents the proper lung expansion. So removing the fluid allows the lung to re-expand and also improve the breathing. So what are the diagnostic indications for performing thoracocentesis? To determine the cause of pleural effusion, for example, infection, malignancy, heart failure, liver or kidney disease. So this fluid is sent for biochemistry lab, microbiology labs and cytological labs. So what are the therapeutic indications? To relieve the breathlessness, remove the large or symptomatic infusions, and emergency decompression. So intention pneumothorax, which is a related concept. And the diagram here showing is the patient is usually sitting upright and leaning forward. So arms are resting on a table or pillow. So this position widens the intercostal spaces and also allows the fluid to collect at the base of the lungs. So now what is the site of this needle insertion? Usually done in the 7th to 9th intercostal space. Needle is inserted just above the upper border of the rib to avoid the injury to the intercostal nerve and also the vessels. So what are the procedure involved here? The first step is skin is cleaned and draped. Second is local anesthesia is given. And third step is needle or catheter is inserted into the pleural space. And fourth is fluid aspirated into the syringe and collection bag. At last, the needle removed and dressing is applied. So these are the procedure steps done in thoracocentesis or thoracentesis. And next procedure is indwelling pleural catheters, IPC. So it is a small flexible tube placed into a pleural space to allow the repeated drainage of the pleural fluid at home or in an outpatient settings. So it is designed for long-term use. So why is an IPC used? It avoids the need for repeated thoracocentesis, for repeated chest tube insertions, for frequent hospital visits. So it allows easy, painless drainage whenever it is needed. So what are the indications for IPC? Recurrent pleural effusion, malignant pleural effusion, chronic effusion not responding to treatment, and patients not suitable for pleurodesis. So how IPC works? According to this diagram, the catheter sits inside the pleural space. So fluid collects around the lung, that is a pleural effusion, and a one valve prevents the air entry. So fluid drains into a vacuum or a negative pressure bottle. So drainage can be done periodically at the home. So what is the procedure overview here? Local anesthesia, small incision in the chest wall, catheter tunneled under the skin, catheter tip placed in the pleural space, external end capped with the valve. And what are the advantages of using IPC methods? So it's a minimally invasive procedure. It's an outpatient procedure. It improves breathing and quality of the life. It involves the reduced hospital admissions. It can also lead to autopleurodesis over time. Next is removal procedures, nothing foreign body in the nose. So this focus to ENT removal procedures, specifically foreign body removal from the nose. So now why foreign body removal is needed? Because it is very common in children. So objects may cause the nasal obstruction, infection, bleeding and foul smelling discharge. So what are the types of removal procedures? Obvious procedure. The code range is 30,200. So simple removal, patient is awake and there is no requirement of the general anesthesia. Whereas in the case of CPT codes 30,310, it involves general anesthesia. The child is uncooperative here. And the object is deeply lodged, which is a risk of aspiration. And third procedure 30320. removal by the lateral rhinotomy, which is a surgical approach. So this is used for the impacted or complicated foreign bodies, for failed simpler attempts, and also it requires the operating room setup. So CPT codes 32440 to 32540, they describe partial or total lung removal. So they also describe the bronchoplastic procedures as well as the resection of apical lung tumors. So these are the major thoracic surgical procedures usually performed for lung cancer, severe infection or trauma. So pneumonectomy codes. Nothing but entire lung removal. So the codes are 32,440 to 445. So they include removal of the entire lung, which is indicated for extensive malignancy or a destroyed lung. So what is the important rule here? If both the lobes of the left lung are removed, so it is coded as the total pneumonectomy 32440, but not the bilobectomy. Next is partial lung resections, which is less than entire lung. So removal of other than total pneumonectomy. So CPT code 32480 to 32491. So this includes lobectomy, bilobectomy, segmentectomy, and sleeve resections. So CPT code 32482 bilobectomy, it includes the removal of two lobes of the right lung, which is not a bilateral procedure. So this cannot be performed on the left lung because the left lung has only two lobes. So removing both includes total pneumonectomy. So bilobectomy means it's only right lung only. And CPT code 32484, which is a segmectomy. So segmectomy, it's a removal of one or more bronchopulmonary segments, which preserves more lung tissue, which is used for early stage cancer and limited disease. So this is very less extensive than the lobectomy. And next code is 32486, which is a sleeve lobectomy. So lobectomy with resection of part of the bronchus. So bronchus is then reconnected within this code description. And it is used whenever the tumor involves the bronchus. It's a lung sparing alternative to pneumonectomy. And this is used when tumor involves the bronchus. It also includes a bronchoplasty procedure. And next CPT code 32488, which includes completion pneumonectomy. So what do you mean by completion pneumonectomy? Removal of the remaining lung tissue after a pre or partial resection. It is considered as a secondary procedure. So what are the examples? Patient had lobectomy earlier. Later he requires removal of the remaining lung. So this is the completion pneumonectomy, which is always considered as a secondary procedure. So these are some of the procedure guidelines which are included in CPT for respiratory system surgery section. So this is for today's session. I hope the session has helped you. In the next session, you will be learning about some more CPT coding surgery guidelines for respiratory system. Thank you.